We described the life cycle of hepatitis C virus and looked at the mechanism of action of direct-acting antiviral agents. Now the next learning objective is given a patient with chronic hep C virus, recommend AASLD-IDSA guideline-concordant first-line therapy.
Now here's some reliable resources. American Association for the Study of Liver Diseases, or AASLD, in conjunction with, in collaboration with IDSA, have developed guidelines for, or I should say guidance for hepatitis C, which are freely available, and they are published online because they get updated frequently. In fact, more than once a year they update it, so they are published online. There's also the HEP drug interaction checker that you can actually, there's also a HEP iChart app that you can download for free, which allows you to check for drug interactions. So here's why, SVR12 is very important. And of course, SVR12 is just a lab value. It's a surrogate marker. So here's why it's important. So cure or SVR12, generally speaking, of course, if somebody achieves SVR12, that's gonna reduce transmission. So if somebody doesn't have the virus in their system, then they're unlikely to transmit it to other people. So that's very important. Another thing is improved clinical outcomes in the patient. And these benefits, clinical outcomes, include hepatic and extrahepatic. So of course, if you cure the hep C, there will be reduced rate of cirrhosis, reduced rate of decompensation in the liver disease, reduced risk of hepatocellular carcinoma, and reduced need for transplantation. And of course, there are also studies that show that SVR12 can actually reduce all-cause mortality, improve quality of life, reduce malignancy, diabetes, cardiovascular disease, and renal and neurocognitive disease. So, and of course, not only does SVR12 reduce all-cause mortality, the interesting thing is that it reduces liver-related mortality as well as non-liver-related mortality. So it's not all about the liver. It actually reduces non-liver related mortality. So that's why SVR12 is, although it's a surrogate marker, it's a surrogate marker for a very important clinical outcomes. So the guideline says the goal of treatment of hep C infected person is to reduce all-cause mortality and liver-related health adverse consequences, including end-stage liver disease and hepatocellular carcinoma, by the attachment of SVR. One of the extrahepatic clinical outcomes is actually diabetes, and in diabetic patients is renal disease. So in this study you can see patients who have diabetes and hep C, and if they're not treated, they are a lot more likely, significantly more likely to have incidence of end-stage renal disease, whereas when you treat them, they are significantly less likely to have end-stage renal disease. So SVR is extremely important for preventing end-stage renal disease in these patients if they have diabetes.
All right, let's take a look at therapy for hep C genotype 1, specifically in treatment-naive patients. So treatment-experienced patients are more complicated, especially it depends on what treatments they have received in the past. That's what treatment experience means. So we're going to focus on treatment naive. So these are patients who have never received treatment before for their infection. And we're going to focus on genotype 1 the most because this is the most common genotype in the United States. And it's also a bit complicated because there are two common subtypes, 1A and 1B. And then for each of these, we're going to consider patients with no cirrhosis and see what the treatment options are for them. And then patients who have cirrhosis but compensated cirrhosis. And then lastly, patients who have decompensated cirrhosis. The first regimen is Harvoni, which includes sofosbuvir and ledipasvir. So for patients with no cirrhosis, 12 weeks of treatment is recommended with this regimen. Now, there is a subgroup of this population where we can do 8 weeks of treatment with this regimen, and that's specifically people who are not infected with HIV and their viral load as baseline is less than 6 million. So, for example, if you have someone who is HIV negative and their viral load is, let's say, 4 million, then that patient is easier to treat and 8 weeks will be sufficient. But otherwise, if someone is HIV positive or if the viral load is 6 million or more, then 12 weeks is required. Now, for patients with compensated cirrhosis, 8 weeks is no longer an option, regardless of whether they have HIV or whatever the viral load is. So 12 weeks is required. And then lastly, for decompensated cirrhosis, 12 weeks of treatment is required in addition with ribavirin. So ribavirin must be added to Harvoni for 12 weeks. Now, if someone cannot tolerate ribavirin, whether they have contraindications or intolerant, then without ribavirin, Harvoni needs to be extended to 24 weeks for these patients with decompensated cirrhosis. The same recommendations apply for genotype 1b. So 1a and 1b doesn't make a difference. For Harvoni, it's the same recommendation. Now, the next regimen is Vicera XR. This regimen has 4 drugs in it. 3 of them are direct acting agents, so that's why this is referred to as 3D sometimes. And I'm going to talk about specific components of this shortly. But because we have so many other options that are much easier than this combination, and because this is pretty much complicated, it's not recommended for anyone really. So you will see that across the board this is not recommended, and literally just because we have much better options. So I'm going to skip for now. The next option is Zepatir. So this one is Elbasvir and Grazoprevir combination. Now this is one where genotype 1A versus 1B is slightly different. So for 1A specifically, there must be a baseline NS5A RAS test, and Zepatir can only be used if this NS5A RAS test comes back negative. Otherwise, if RAS is positive, another regimen must be used. So Zepatir cannot be used. So because of this reason, Zepatir is only recommended as an alternative. So it is not first line for genotype 1A in non-cirrhotic patients or even with compensated cirrhosis. It's only an alternative. And of course, it's contraindicated in patients with decompensated cirrhosis because it does have a protease inhibitor in it. Now, this is a different story with genotype 1B because this NS5A RAS doesn't exist in genotype 1B. So it's not required to test at baseline for NS5A RAS for genotype 1B. So because of that, it is recommended first line, either for patients who do not have cirrhosis or if they have compensated cirrhosis for 12 weeks duration. Now, the next option, which is pretty popular, is Epclusa, which is sofosbuvir and velpatasvir. So this is similar to Harvoni. In fact, the same manufacturer makes this. So velpatasvir is a second generation NS5A inhibitor. So as a result, it is pangenotypic. So this combination covers pretty much all genotypes 1 through 6. And you will see that 12 weeks is recommended for no cirrhosis and compensated cirrhosis. And it doesn't matter if it's genotype 1A or 1B. Now, for decompensated cirrhosis, this is recommended since it does not have a protease inhibitor in it. But you do need to add ribavirin. So it's 12 weeks of Epclusa, and you got to add ribavirin to it. And if someone cannot tolerate ribavirin, or if they have contraindication, then you do it without ribavirin, but you extend to 24 weeks. And the same applies to 1A and 1B. Now, the next option is Vosevi, which is pretty much Epclusa, and it adds a protease inhibitor to it, so voxilaprevir. And this is not recommended across the board because we are reserving this for patients who have resistant viruses that are not responding to to any other regimen. So basically, this is a very effective regimen, and we're just reserving it for people who fail, let's say, Epclusa or Zepatir or Harvoni. So we want to make sure that we have one option reserved. So that's why it's not recommended for treatment-naive patients. It is often used for treatment-experienced patients. And the last regimen is Maviret, which is galecaprevir, pibrentasvir. And this one is pretty nice because you will see that for most patients, 8 weeks of treatment is sufficient. So for no cirrhosis, 8 weeks is recommended, and for compensated cirrhosis is 8 weeks recommended, as long as the patient does not have HIV co-infection. So if someone is HIV positive, 12 weeks is recommended. But otherwise, for someone who is HIV negative, 8 weeks is recommended. And because gilteritinib is a protease inhibitor, this regimen is contraindicated in decompensated cirrhosis. All right, let's take a look at Harvoni, which includes sofosbuvir, NS5B inhibitor, which is basically a polymerase inhibitor, as well as letetresvir, which is an NS5A inhibitor. Now you can see that between these two, sofosbuvir is about 80% eliminated renally, whereas letetresvir is primarily eliminated through the feces. Now historically, because of these 80% renal clearance, sofosbuvir was contraindicated if GFR was less than 30. However, recently, because of recent data that we've had in patients with end-stage renal disease, you can see here there's a screenshot of the package insert for Harvoni, where the FDA actually says that it's okay to use Harvoni without dose adjustment in patients with end-stage renal disease, as well as those on dialysis. Now, one thing about sofosbuvir is that it has a high barrier to resistance, and what that means is that it is more difficult for Hep C virus to develop resistance against sofosbuvir, whereas letetresvir, as a first-generation NS5A inhibitor, has a low barrier to resistance. The next combination, which is the Pro-D, actually includes 4 drugs. 3 of them are directed at the Hep C virus. So dasabuvir is a NS5B polymerase inhibitor, onbitasvir is a NS5A inhibitor, and paritaprevir is a protease inhibitor. Now you will notice that ritonavir, which is actually an HIV drug, is actually used in combination with this regimen, and it really does nothing. It does absolutely nothing to the Hep C virus. What it does is that it's a strong CYP inhibitor, and because protease inhibitors in general are substrates of the CYP enzymes, specifically CYP3A4 more than anything, by having ritonavir block the metabolism of paritaprevir, you can actually give a smaller dose of paritaprevir, which will help with the size of the pills. So what we do is that we use ritonavir as a pharmacokinetic booster. And what that means is that it actually boosts the concentrations of paritaprevir by inhibiting its metabolism. So really, although there are 4 drugs here, only 3 of them are direct acting agent. And you will see that ritonavir typically will be represented by a slash and an R when it's used as a booster. So it's basically boosting paritaprevir. Now you will see that pretty much all of these agents are, administered with food. So food is very important when this regimen is given to patients. And you will see that these are primarily eliminated through the feces. And all of these 3 have a low barrier to resistance. So that's why there are 3 of them, because none of the agents used here have a high barrier to resistance. So 3 of them are used in order to prevent emergence of resistance. Now here's what the original Vicera pack looked like. So it came with a pack. So each pack is for 1 day, and then it will 7 packs would be a box, so there will be 1 box for a week. And then they did a good job of showing that half of it you need to take it in the morning, so AM, with a picture of the sun, and then 1 pill you need to take in the afternoon or in the evening, so they have the picture of the moon, and they all need to be taken with food. As you can see, there are 4 pills, so 3 of them are given in the morning, and then another one at night. So it's twice a day dosing. So not only so many pills, but also twice a day. So it made it very complicated. But to make things worse, you also need ribavirin, especially if the patient has genotype 1A. So in addition to this pack, you also need a bottle of ribavirin, which is actually dose based on body weight. There are also pre-packed ribavirin formulations to make it a little easier. So this needs to be taken twice a day too. So this made it very complicated. Now, more recently, there was a Vicera XR. So basically, instead of 4 tablets, there are 3 tablets that you take at the same time. So instead of twice a day dosing, it's once a day dosing. So it's relatively easier to take. But regardless, you still need that ribavirin in a bottle, and ribavirin needs to be taken twice a day. So it's still pretty complicated. And this is, in fact, the reason that this regimen is no longer recommended first line. It is only an alternative. Now, let's take a look at Zepatier. So Zepatier also comes in a pack, but it's only a single pill that's taken once a day. One thing significant about Zepatier is that these are second generation protease inhibitor. So Grazoprevir is a second generation protease inhibitor, and Elbasvir is a second generation NS5A inhibitor. And what that means is that they have high barrier to resistance. So they're going to be very effective. It's going to be difficult for the virus to develop resistance, but also they're more tolerated. So second generation also means better tolerated. Now, these are basically eliminated through the feces, so no issues in renal dysfunction. Now, let's take a look at Epclusa. So Epclusa, again, includes sofosbuvir, but what's different from Harvoni is that instead of a first generation NS5A, they actually replaced it with a second generation NS5A inhibitor, velpatasvir. So because of that, velpatasvir has a high barrier to resistance and also better tolerated. And of course, because this includes sofosbuvir, which is 80% renally cleared, this used to be contraindicated in GFR less than 30. But you can see that the updated package insert says that the FDA says no dosage adjustment needed in end-stage renal disease, including those who require dialysis. Now, Vosevi is basically Epclusa plus another agent. So voxilaprevir is a second generation protease inhibitor. So you have 3 high barrier agents here. So that's why this is a very potent combination, and it's reserved for treatment experienced patients who fail other agents. That's why it's not recommended first line. And of course, this also has sofosbuvir, which is renally cleared. And again, the package insert says you don't need to dose adjust in end-stage renal disease, including dialysis. Harvoni, Epclusa, and Vosevi, they're all a single tablet once a day. So they're really nice for the patients. It helps with compliance. Now, Mavuret, which is really popular because, for most patients, 8 weeks of treatment is sufficient. So, that makes it really convenient for the patient. It does include 2 second generation agents, one NS5A inhibitor and one protease inhibitor, so high barrier to resistance. They're not renally clear, so really, really nice combination. Now, it is 3 pills, but you take it once a day. So even though it's 3 pills, it comes in a pack, so it makes it easy for the patients to take all 3 at the same time, and they do need to be taken with food. Now, that was all for genotype 1. For genotype 3, it's important to consider a few things. First of all, genotype 3 is the second most common genotype globally. So genotype 1 is by far the most common. Genotype 3 is the second, but also genotype 3 is the most difficult to treat. And specifically genotype 3, it can actually progress to fibrosis a lot faster. So patients will be at high risk of hepatocellular carcinoma and complications of hepatitis C. And we don't have as many agents again. So pretty much most of the agents that we have had over the past few years didn't have activity against genotype 3. Except recently with the newer agents, they are typically pangenotypic. So now we're starting to have good regimens that have good activity against genotype 3. So when it comes to genotype 3, you will see that, Harvoni is not indicated because it doesn't have activity Specifically, Ledipasvir doesn't have activity against genotype 2 or 3. In this table, I'm showing you genotype 2 and 3. The same thing is true about Pro-D and Zepatir. So these are not used for genotype 2 or 3. And so the two regimens that we use for treatment-naive patients is Epclusa and Mavyret. So Epclusa for genotype 2, if the patient has no cirrhosis or compensated cirrhosis, 12 weeks was enough. And then for decompensated, you need ribavirin, so similar to genotype 1. When it comes to genotype 3, for patients who have compensated cirrhosis, for Epclusa, we also need to check NS5A resistant associated substitution. So if there is a mutation detected, then the patient actually can use Mavyret instead. So Epclusa would be an alternative if the patient has that mutation detected. Otherwise, Epclusa is recommended first line. Now, when it comes to Mavyret, 8 weeks is recommended for no cirrhosis, and then for compensated cirrhosis, 8 weeks is recommended as long as the patient does not have HIV. If the patient happens to have HIV for compensated cirrhosis, then 12 weeks is recommended. The same is true for genotype 3. And of course, Vosevi we save, for treatment experienced patient. It is active against genotype 2 and 3. As you can see with genotype 3 for compensated cirrhosis, because we only have 2 options and one option potentially will be an alternative because of RAS, Vosevi is recommended as an alternative for treatment-naive patients. But other than this, Vosevi is not recommended for treatment-naive patients.